Welcome to Dr. Balga's podcast for the Curious Doc. Today is Feb 3rd, 2026. This video is on a Nature Reviews Cardiology article titled Residual Cardiovascular Risk in Coronary Artery Disease From Pathophysiology to Established and Novel Therapies. It's a terrific article. It includes residual thrombotic risk, residual lipid risk, residual metabolic risk, residual inflammatory risk, and emerging factors. What is residual cardiovascular risk in coronary artery disease? It's the ongoing risk of recurrent ischemic events that persist despite optimal secondary prevention and good control of conventional risk factors. Why does residual risk persist even with guideline-directed therapy? Because current therapies only partially address all atherothrombotic pathways. Additional mechanisms, coagulation, fibrinolysis, inflammation, metabolic dysfunction, and emerging factors continue to drive events. Is residual risk the same in every patient with coronary artery disease? No. Dominant pathways differ across individuals, so the residual risk mix varies and may benefit from tailored interventions. What are the main domains of residual risk discussed in this review? Residual thrombotic risk, residual lipid risk, residual metabolic risk, and inflammatory risk, plus emerging and novel contributors. Which secondary prevention pillars are considered baseline before targeting residual risk? Lifestyle modification, antithrombotic therapy, blood pressure control, and LDL cholesterol lowering. What are the three key pathways underlying residual thrombotic risk after an acute coronary event? Coagulation, platelet reactivity, and endogenous fibrinolysis. Why is impaired endogenous fibrinolysis important after myocardial infarction? When fibrinolysis is impaired, thrombotic occlusion and subocclusion is less effectively countered, increasing the risk of recurrent ischemic events. What is D-dimer and why is it relevant to residual thrombotic risk? It's a degradation product of cross-linked fibrin. Elevated levels have been associated with higher long-term adverse cardiovascular events after acute coronary syndrome. What is fibrinogen and how is it clinically used in chronic coronary syndromes? It's a coagulation factor. Elevated levels of fibrinogen have been linked to adverse outcomes. And the European guidance recommends fibrinogen assessment for future risk prediction, a class 2A level B recommendation. What is tissue factor and what does its elevation suggest? It's a key initiator of extrinsic coagulation cascade. Higher soluble and platelet-derived levels have been associated with worse long-term outcomes. What is von Willebrand factor in this context? It's a glycoprotein involved in platelet adhesion under shear. Elevated admission levels predict adverse outcomes in acute coronary syndromes. How is thrombin linked to inflammation in CAD? Thrombin promotes platelet activation and fibrin formation and can also trigger pro-inflammatory pathways, bridging thrombosis and inflammation. What are the examples of markers in vivo of thrombin generation mentioned? Prothrombin fragments and fibrinopeptide A. Higher levels around ACS or PCI have been associated with adverse outcomes. What is PI1 and what does it indicate? Plasminogen activator inhibitor 1. Higher activity and levels reflect impaired fibrinolysis and have been linked to restenosis and recurrent events. Why are viscoelastic tests discussed for thrombotic residual risk? They can assess global clot strength and endogenous fibrinolysis, potentially overcoming variability and cutoff issues of single biomarkers. What is higher platelet reactivity on clopidogrel and why does it matter? Reduced antiplatelet response is seen in around 30% in some cohorts, associated with higher thrombotic events, including stent thrombosis and cardiovascular death and myocardial infarction. How can CYP2C19 genotyping help in coronary artery disease patients treated with clopidogrel? The loss of function alleles predict poor clopidogrel activation. Testing can guide switching to more potent P2Y12 inhibitors when needed. What are reticulated platelets and why are they relevant? They are newly released RNA-rich platelets with higher prothrombotic potential. Higher levels are associated with reduced antiplatelet response and worse outcomes. What are platelet-derived microparticles and what do they reflect? Vesicles from activated platelets expressing procoagulant phospholipids and tissue factor. They can serve as biomarkers of thromboinflammation. What is soluble CD40 ligand and why is it mentioned? It's a platelet-derived mediator involved in thrombosis and inflammation. Higher levels are seen after ACS or PCI and have been associated with adverse events. What is P-selectin and what does it indicate post-PCI? It's a marker of platelet and endothelial activation. Higher levels have been linked to worse outcomes after myocardial infarction and PCI. What is extended DAPT and when is it considered? It's dual antiplatelet therapy beyond 12 months after ACS. It can reduce ischemic events in high ischemic risk patients, but increases bleeding, requiring individualized decisions. What is dual pathway inhibition? Low dose rivaroxaban 2.5 mg twice daily, plus a single antiplatelet agent, often aspirin, targeting both platelet aggregation and thrombin-mediated coagulation. What's the main trade-off with DPI? Lower MACE and cardiovascular death in some settings, but higher major bleeding, limiting use to high thrombotic risk and low bleeding risk patients. What is P2Y12 inhibitor monotherapy and why consider it? Using a P2Y12 inhibitor, example clopidogrel, without aspirin in certain settings to balance ischemic and bleeding risk. How can platelet function testing be used practically? To identify clopidogrel non-responders who may benefit from switching to prasugrel or ticagrelor, while responders might continue clopidogrel to reduce bleeding risk. Why are factor 11 and factor 11A inhibitors discussed as future DPI enhancers? They may provide anticoagulation with lower major bleeding risk than factor 10A antagonists, potentially broadening intensified antithrombotic strategies. What LDL cholesterol target is highlighted for secondary prevention in CAD? A target less than 55 mg per deciliter or less than 1.4 millimoles per liter is cited for secondary prevention in patients with coronary artery disease. Why do many patients still have residual lipid risk despite statins? Because LDL goals are not achieved in many patients, and non-traditional risk factors like Lp(a), ApoB, and remnant cholesterol may remain elevated. What is Lp(a) and why is it important? It's an LDL-like particle, apolipoprotein A, bound to ApoB. Genetically determined levels are associated with higher risk of coronary artery disease and contribute to residual risk. How often should Lp(a) be measured according to this review? Once in a lifetime is recommended, given a strong genetic determination and guideline support. Why is ApoB considered a useful marker of residual lipid risk? It reflects the total number of circulating atherogenic particles. ApoB can identify risk even when LDL cholesterol appears to be normal. What are small dense LDL particles and why do they matter? They are more atherogenic, more oxidation prone, and can be elevated even with normal LDL cholesterol, associated with adverse events in coronary artery disease and acute coronary syndrome. What is non-HDL cholesterol and when is it especially useful? It's total cholesterol minus HDL cholesterol, useful in high triglycerides, diabetes, obesity, metabolic syndrome, and very low LDL cholesterol levels. What is remnant cholesterol and why is it relevant? Total cholesterol minus LDL cholesterol minus HDL cholesterol. Higher levels predict recurrent events in secondary prevention cohorts. What is cholesterol efflux capacity and how does it relate to HDL? It's a functional measure of HDL's ability to remove cholesterol from macrophages. Lower efflux capacity is linked to worse outcomes independent of HDL cholesterol. What's the role of ezetimibe in residual lipid risk mitigation? If LDL goals aren't met on maximally tolerated statin, ezetimibe is recommended. It can further reduce ApoB and other atherogenic fractions. How do PCSK9 targeted therapies affect Lp(a) and ApoB? They lower Lp(a) by 19 to 27% and can reduce ApoB substantially when added to statin therapy. They also reduce small LDL, remnant cholesterol, and non-HDL cholesterol. What is inclisiran in simple terms? It's a small interfering RNA therapy that reduces PCSK9 production, leading to LDL lowering and modest Lp(a) reductions. Where does bempedoic acid fit in lipid residual risk? And it is an ATP citrate lyase inhibitor useful in statin intolerance. Has minimal effects on Lp(a) but can reduce ApoB and non-HDL fractions. Which two drug classes are emphasized as major advances of metabolic residual risk? SGLT2 inhibitors and GLP-1 receptor agonists. How does SGLT2 inhibitors lower glucose? They block SGLT2 in proximal renal tubules, promoting urinary glucose excretion or glycosuria. There are several other mechanisms. Beyond glucose lowering, what body composition effects are linked to SGLT2 inhibitors? Reductions in hepatic and visceral pericardial fat depots and modulation of inflammatory and metabolic mediators. What are guideline recommendations for SGLT2 inhibitors in a coronary artery disease context? Recommended class 1 level A in patients with heart failure, including HFpEF or mildly reduced EF, and in patients with type 2 diabetes and coronary syndromes independent of hemoglobin A1C targets. What are the core mechanisms of GLP-1 receptor agonists? They enhance insulin secretion, suppress glucagon, slow gastric emptying, and promote satiety, supporting glycemic control and weight loss. What cardiovascular outcomes signal is highlighted for semaglutide in non-diabetic patients? In a large trial of patients with established cardiovascular disease and overweight or obese without diabetes, weekly semaglutide reduced cardiovascular death, myocardial infarction, and stroke composite endpoints. What are guideline recommendations for GLP-1 receptor agonists in coronary artery disease context? Recommended class 1 level A for type 2 diabetes with CCS and class 2A level B for CCS without diabetes in patients with BMI equal to or greater than 27 kilos per square meter. Why is atherosclerosis described as an inflammatory disease? Inflammatory cells accumulate in plaques. Inflammatory biomarkers predict events, and anti-inflammatory therapies can reduce cardiovascular risk. What inflammatory biomarker is widely used and the preferred clinical use? HSCRP or high sensitivity C-reactive protein. How is it commonly categorized? High risk when HSCRP is greater than 3 mg per liter and moderate risk if 1 to 3 mg per liter. A cutoff of 2 mg per liter has been used in trials. What cytokine is described as a major driver and predictor of events independent of HSCRP? IL-6 or interleukin 6. What is NLRP3 inflammasome and what's its relevance? It's an innate immune complex. Higher levels or higher activation associated with higher MACE and cardiovascular death than ACS. Which anti-inflammatory therapy is noted as guideline recommended for residual inflammatory risk in coronary artery disease? Low dose colchicine 0.5 mg daily recommended with class 2A level B in CCS with atherosclerotic coronary artery disease to reduce MI, stroke, and revascularization. What overall effect sizes are reported across trials for colchicine in CAD? Across multiple randomized controlled trials, reduction in MACE, myocardial infarction, stroke, and revascularization were reported. Though not all trials were concordant, large anti-IL-1 beta trial is mentioned, and what is the key finding? Canakinumab lowered hsCRP and reduced MACE events in patients with prior MI and hsCRP equal to or greater than 2 milligrams per liter, but increased fatal infection and is not approved for residual risk reduction. What did low-dose methotrexate show in coronary artery disease inflammatory risk trials? It did not reduce IL-1 beta, IL-6, or CRP, and did not improve cardiovascular outcomes versus placebo. Name examples of emerging or novel contributors to residual risk beyond the 4 classic domains. Examples include CHIP or clonal hematopoiesis of indeterminate potential, gut microbiota, exposures or exposome, infectious disease, cancer or chemotherapy or radiotherapy, microRNAs, polygenic risk scores, and others. How is artificial intelligence positioned in the context of residual risk? As a tool to analyze complex datasets, improve patient stratification, and identify optimal therapeutic targets. Go ahead and read this review in Nature Reviews Cardiology. It's an outstanding overview of residual risk. Podcast brought to you by masterbedfacts.com. This podcast is for physicians and healthcare providers. If you enjoyed this video, please like, subscribe, and forward to your friends.